This is a presentation of Dr. C on spinal cord and spinal column injuries. It's been a topic that's been requested by a number of you. So we are very excited to announce that Education Department is going to be working with us now and going to be able to offer CEUs for the nurses that are online live with us. So a big thank you to Melissa Plate from the Education Department and the Education Department as a whole. And this is a new process for us. We're really excited to be able to offer it to you. And there may be some streamlining and some bumps along the way, but we are excited to be able to offer this now. So I will turn it over to Dr. C whenever she is ready.
Okay, and just because I'm technically challenged, are you guys able to see my screen with the slideshow presentation?
Yes.
Okay, perfect. All right. And then please feel free to interject, raise hands. I will try and keep an eye here for raised hands and or chats. So it's meant to also be interactive. So please feel free to stop me at any point. Because we now thankfully do get to offer the CMEs for the nurses, we've added in some objectives. So here, what I would hope to accomplish during my time with you guys this morning is to illustrate how to care for a patient with spinal column and or spinal cord injury across the entire care continuum. So we're going to be talking from pre-hospital all the way up to the time of discharge and going to hopefully rehab for these patients. We're going to describe some common mechanisms related to the injuries, as well as discussing medical and nursing interventions for the sequelae of these spinal cord injuries and how we manage them here in the hospital. And then how to maintain and manage appropriate spinal precautions in the hospital as well. So have some cool videos for you guys. Hopefully they will be working. Going the wrong way. So there's nothing to disclose. And again, just in case I didn't officially introduce myself, I'm Stephanie C. I'm one of the trauma surgeons here at Peace Health Southwest, and talking to you guys again about spinal injuries today. So let's get right into it. There's a lot to talk about. This topic is extremely broad. And it sounds as though a lot of the nurses and a lot of the team have brought forth a lot of questions to Lee and Alan in regards to spinal immobilization and collar wearing and all those things, because we do have quite a significant amount of patients here that are admitted that require cervical collars, TLSO braces, and such. So this talk is not meant to be all encompassing, but just to try and kind of reach on some heavy hitter and some big topics, just so that we all have a better understanding of what spinal injuries are, things to look out for, and then how we can really help our patients to really get to really good rehab and to become functioning patients again. So spinal column fractures represent 4 to 23% of all fractures from traumatic injury, but their significance is what is the most important thing. So these have the potential for long-term disabilities, and associated morbidity and cost is significant. So millions of dollars, healthcare dollars every year spent on not only in hospitalization for these injuries, but the long-term sequelae of them. Management is often unclear, and that is very well demonstrated here. It's very individualized. It's based on fracture patterns. It's based on patient age. And so we'll go through that as well during this talk. The diagnosis and or treatment can often be delayed, especially in the trauma situation, because it is often secondary to more life-threatening injuries that are happening. So, the bleeding patient or the severe, head trauma that needs a cranie as well, or perhaps they're severely hypotensive. Those are all going to be, of course, more important and take precedence, and then the actual fractures kind of come later. As y'all know, with our aging population and increasing incidence of traumatic spinal injuries, these patients have stiff spines, they have osteoporosis, multiple comorbidities, diabetes, COPD, and just making these very difficult elderly patients difficult to treat. Also frailty scores, you'll hear about that, so also complicates things. I'm going to walk through this talk today with a patient of ours. As we kind of talk about him, some of you may or may not remember him, but we'll just say this patient was CB. This was not CB. He successfully did not climb the tree. He actually ran into the tree at a very high rate of speed. They report 90 miles per hour. Positive loss of consciousness on the scene for almost 30 seconds per bystanders. He was noted to not be moving when paramedics got there. So bilateral lower extremities were not moving. Kind of had some decreased sensation there, but just overall had a lot of problems secondary to his motorcycle crash. So that's just kind of setting up the patient that we're going to be talking throughout this talk, and I'm just going to interject with some kind of some good facts about spinal cord injuries along the way. So MVC, and under that umbrella is motorcycle, also unintentional falls, which we know as ground level falls here, are the leading mechanisms of injury. Older adults are more susceptible, secondary to their risk of increased falls and presence of those comorbidities, so their underlying arthritis and osteoporosis. Spinal cord injury is estimated at 55 per million patients, so still pretty significant. Little data of incidence of spinal cord fractures, but extrapolated to be 8 times higher than spinal cord injury. So that's just saying, you know, the actual spinal cord injury is minimal, but those that have actual fractures somewhere along that entirety of the spine in a trauma is much, much higher. And we can see that clearly based on our patient population. 13% of blunt trauma patients in the National Trauma Database in 2010 had at least one spinal cord fracture. So clearly this is a very common injury pattern. Total number of spinal cord injuries is continuing to rise. So this is attributed to the rising age of our patient population, changes in human behavior. As we're getting out, we're traveling more, people are doing more risky behavior, riding those dirt bikes, and biking and driving faster and such. There also is a higher rate of survival at hospital admission. So thanks to our excellent pre-hospital care as well as trauma care, people are actually surviving these big traumas and living through. So now we're having to see the sequelae of these types of injuries long term. Again, causes of the spinal cord injuries, most commonly 30 to 40% are attributed to the motor vehicle collisions. Depending on the country, ground level falls is the second most common, but you can see in some countries, even up to 2/3 of their injuries are all related just to ground level falls. And then interestingly enough, penetrating and or injury secondary to like firearms, so gunshot wounds, is second, but it's way less to all these other causes. So about 5% secondary to penetrating. When you look at what's the most riskiest sports behavior for spinal cord injury, it's actually diving and skiing. Although I think some of us would beg to differ and say that it's probably motocross here. But diving and skiing are traditionally thought to be the most risky. So about 5% of our patients with brain injury will also have associated spinal injury. But if you look at it the other way, 25% of those with spinal injury will have concomitant head injury as well. So it just goes to show you that these things run together. Cervical spine is by far the most common injury, and then followed by thoracic, thoracolumbar, and lumbar sacral areas. And again, this is just showing if you have a C-spine injury, the incidence of you having a second injury somewhere down that entire vertebral column is pretty common. So up to 10% of patients will have that secondary injury. Our stats here, so we kind of quick snapshotted, Danielle went back through our registry for 2024, just to kind of be able to show you guys what we actually saw here at Southwest. And spinal cord fractures that were actually admitted. So these aren't a lot of times patients do come in, we have incidental fractures, they end up getting discharged or going home. But ones that were actually admitted, we admitted 97 patients last year to the trauma service. And then you can see the breakdown for us of where those levels were. So cervical fractures were 30, thoracic 38, lumbar fractures 29. And then from that, you can see even then a smaller proportion of those went to the OR for some sort of stabilization, decompression for those fractures. Now, of those spinal cord fractures, those that actually had associated spinal cord injury were 16. And again, cervical injuries being the most common. So 11 with injury at the cervical region, 5 of which went to the OR. Thoracic, there were 3, 1 went to the OR, and lumbar injuries, there were 2 of which both went to the OR for us. So that kind of just gives you a breakdown of what we see here at Peace Health. So again, getting back to these older adults, it is such a large proportion of our patient population here, and patients that we see admitted and treated. And the reason why these patients are so high at risk is because they have underlying conditions such as osteoporosis and osteoarthritis, which I mentioned in the past. They also have ankylosing spondylitis, so they have that, that bone that's just really bad backbone that's starting to fuse together, and therefore it makes it really easy when they break to cause some severe damage there. It's also a disease called diffuse idiopathic skeletal hyperostosis that also contributes to worsening injury patterns. Again, upper cervical spine is the most common injury location in the elderly population. Their spinal cord injuries tend to be incomplete, so you'll see a lot of central cord extension distraction, so kind of that falling back head type injury, odontoid fractures. We'll go into a little more detail on all of these a little bit later, but those are the most common for the elderly. And again, central cord secondary to cervical spondylosis is the absolute most common one. And I know you guys have seen it, and we've actually had several patients here with central cord. So overall morbidity and mortality for these type of injuries, I kind of alluded to this earlier. Early mortality is actually 4%. So when patients have these, they have sometimes really high severity scores and have a high rate of mortality. If you add in a spinal cord injury on top of that, the rate almost doubles at 7%, with tetraplegic patients obviously being a very high risk. That mortality rate then doubles again after 1 year, and that's just associated with kind of the post-traumatic sequelae. Again, we'll hit on this later on, but the deep ulcers, the respiratory insufficiencies, the infections, kind of everything that happens long term really ups that mortality risk for these types of patients. Compared to all of our other trauma patients, they have a much longer length of stay. So it's estimated to be 2.5 times longer, just because they're requiring so much extra care and kind of time to get them to appropriate rehab situations. This is old data, but 2009 already $1.7 billion a year attributed to admissions alone for spinal cord injury. So this does not even include like the readmissions, especially within that first year, the post-injury rehab, so the stents at rehab, inpatient stay, long-term morbidities, long-term care that these guys are requiring in order to successfully go home. And obviously their lost years of employment. Most times these people cannot return to their prior state of function and or living and employment. And so that really does create many more years of requiring assistance and aid. Not to mention the associated cost of long-term recovery, chronic pain, and inability to return to their baseline activities, even in spinal cord fracture patients. So again, I'm sure this number is much, much larger. Just some common definitions I just added in real quick. These are kind of things a lot of times I will say C-spine, again, that's cervical spine, T-spine, thoracic, L spine for lumbar. You may hear us say cervical collar. Again, that is can mean extrication collar versus extended wear versus soft or shower collar. I'll get into those details, but if you hear me say C collar, again, that's just a cervical collar. TLSO braces we talk about often. Those are the big thoracolumbar sacral orthosis. And then when we talk of like full spine precautions, this is when you actually have from top all the way down. So cervical, thoracic, lumbar, sacral spines have not been cleared, or injuries have actually been diagnosed that we have to keep them in full spine precautions. Hard collar at all times, unless an emergent airway, and so supervised by a physician, and we're taking off that collar to do a procedure real quick. You have to do full log roll, bed rest, head of bed, flat at all times. Therefore, if you need a patient sit up, either some reverse Trendelenburg or Trendelenburg the other way if you absolutely need it. Okay, let's get into pre-hospital. So remember that patient, our motorcyclist who struck the trees down on the ground. Let's talk about some pre-hospital situations, things that our EMS physicians are doing out in the field. So when we talk about this, a lot of us talk about immobilization or cervical collar immobilization, but it's not truly immobilization. We're just spinal restriction. So the true definition that a lot of papers and literature will use is SMR, or spinal motion restriction. And this is just that we're trying to keep the spine in a neutral position to limit and reduce undesired motion. We absolutely cannot provide true immobilization unless, the person magically went to the OR and was fixated. So again, our goal here is just to keep these as neutral as possible. Pre-hospital, they'll use things such as backboard, scoop stretchers, you'll hear vacuum splints, even just the ambulance cot, that's what they've got. Any other similar devices to keep these patients as spine neutral and motion restricted as possible. Oftentimes we'll see cervical collars get placed if there's a penetrating injury, but there's really been shown no role for immobilization, or restriction. See, I even say it inappropriately, but spinal restriction with penetrating trauma. And again, that's just because the risk of true injury is so low. What you will see is perhaps someone with a gunshot wound to the neck or stab wound to the neck, and what paramedics are doing is using the cervical collar as a way to help keep the dressings in place, and that's completely appropriate, but just kind of in the back of their mind know that it's not absolutely necessary. And when the restriction is indicated, we're applying this to the entire spine, not just one portion of the spine, not just the C spine. If we're going to be doing this, we have to do it to the entirety of the spine. So indications for this will be an acutely altered level of consciousness, if a person's intoxicated. So if you cannot clearly discuss with the patient and clinically clear them, always use precaution. If they have actual midline neck or back pain, if they have focal neurologic signs, if they're seeing an anatomic deformity of the spine, and of course, any distracting injury. So, their femur hanging out of their leg is clearly going to distract them, and they're not going to be able to tell you that I have a pain in my neck. They may, but it's often common that they can miss that. So that's why pre-hospital, we're really encouraging to put on those extrication collars and backboards to get them here safely. SMR truly cannot be properly performed with a patient in a sitting position. I know there's difficult times when these patients come in. They're COPD patients, their body habit is as such that it makes it a little bit difficult. So I know that slight, like head of the bed 30, or if they're doing a slight reverse Trendelenburg is often best. And again, this is all risk of patient manipulation has to be weighed against the benefits of the device. So it's all kind of this risk-benefit ratio. And once they're at the hospital, it really is a priority of us to expeditiously evaluate and remove all unnecessary things. So these are not without consequence. They do cause pressure ulcers. They are extremely uncomfortable for the patients. And so we do really try to get them off as quickly as possible. But you do need a sufficient number of properly trained individuals. And we're going to watch a video for a true log roll, and you need 3 people minimum to do an appropriate log roll. You need that 4th person if you're actually examining the back and getting a sufficient exam. So it requires a lot of people, hence why we all are there and physically present in the trauma bay to help assess these patients. Also, big thing is reducing patient transfers as much as possible. So, once they get them on the backboard, that backboard then stays as the restrictive kind of device, and moving things, around with that and minimizing their transfers. Again, this is all just trying to limit any actual rotational or further injury to the spinal cord or column. Let's see if my video works. Shoot. Let's see. This is supposed to be a nice, cute video on your extrication collars. And let's see if I can get it to play. No. Okay, well, of course it doesn't want to play. Anyone have any advice real quick? It's a really good video. Anyway, so what this is, I will talk you through it. So extrication collar, these are the collars that you will see when they come in. Let me actually escape and see if I can play it from this. Just take a second.
Yeah, Dr. C, if you might try to do it not from your PowerPoint.
I know, that's what I was. Well, the links are all embedded, and it clearly worked this morning when we were trying, and of course, it doesn't want to do it now. Okay, well, like I said, you'll just get to hear me talk right now. So extrication collars, these are the soft moldable kind of temporary collars that we talk about that we come in with pre-hospital that EMS uses. They start slide animation. Sorry, I thought I got it. Did you know how to get it?
I don't think there's an actual video attached.
It was this morning. I wonder if when we open it. Sorry, Danielle's here trying to help me.
Someone will put it in the slideshow.
We'll put in the slideshow later.
Chat.
I'm seeing Alan too. Perfect. Anyway, so these are the big extrication collars that are moldable. This video will nicely display how to, because when they come, they're nice and flat, and you actually have to pull that chin piece down. You have to set the height, and then while holding proper immobilization restriction of the spine, you place these around the patient's neck in an appropriate manner. So again, we'll put this link in. There's some really good videos on this, and I'm afraid the rest of my videos probably aren't going to work either. So we'll get those all linked to you guys.
Just make sure you start sharing.
Oh, and I'm not sharing. See, I'm really bad at this, you guys.
It's over here for. After you did it, I don't know what I'm doing. Go up. Go up. Left. I cleaned out.
Just show me. Okay, back at it. Okay. So, how do we clear collars? So we come in, we have these extrication collars. We don't want them any longer. So a lot of Nexus and CCR Canadian C-spine rules. That's what you hear. That's kind of the buzzwords. That's what we all talk about. That's where all of this data has come from. So let's first start talking about Nexus criteria. So This was a study back in the day. They took over 4,000 asymptomatic patients out of 34,000 blunt trauma patients. Kind of looked at them all prior to use of routine CT scans. So this is when they were still obviously following good clinical exam as well as using x-rays. These patients had the traditional 3-view cervical x-rays. And then because this was a study, they were able to get that cervical CT scan. Again, not as good of a modality or as good of CT scans that we have today. But nonetheless, they followed this along their 5 criteria. This is kind of a nice mnemonic to think of if you think of it as in spine. So did they have midline posterior spinal tenderness present? So spine tenderness. P, was there a painful, distracting injury present? I, were they intoxicated? In, were there any neurological or focal neurologic deficits present? E, was there any encephalopathy? So any altered level of consciousness in the patient. And if none of these were present, nexus criteria then would say that these were awake asymptomatic patients and could therefore be cleared. And they actually showed a negative predictive value of 99.8% and sensitivity of 99%. So actually pretty good criteria, again, in your awake asymptomatic trauma patient. Canadian rules also looked at this, cervical spine rules. They examined based on 3 different types of criteria, and they looked at almost 9,000 adults. So their first criteria was there any high risk factors? So for them, age greater than or equal to 65, was there a quote unquote dangerous mechanism? So high, was there high rate of speed? Was there a certain fall? If not, was there any known paresthesias in the extremities? So if they were completely symptom free, no, then you could go on to the next set. Yes, it automatically went to radiograph. So was there low risk factors, which allowed for a safe assessment for the range of motion? So was this just a simple MVC? Were they in the sitting position in the ED? Were they ambulatory at any time? So did they come walking in from triage? Was it a delayed onset of pain or complete absence? And again, if those were all negative, then you would ask them to actually rotate their neck left and right. And if they were able to do that, then they were clinically cleared. If at any point in this, the situation broke down and there was a positive symptom, then they would go to radiography. So these were a lot more stringent, but they actually had a sensitivity of 100%. So these were actually found to be much more sensitive in reducing the need of additional imaging. But I think if you kind of look at it, these were much harder to find these patients that actually met all these criteria. This is a very common patient we see. You know, we're sitting there, we're waiting for the trauma patient to come in. They're wearing their brace, talking on their cell phone, coming down the stretcher, and we're just all kind of like rolling our eyes. So what I will say with this is, again, additional studies have looked. They did a massive meta-analysis in 2010, looking at 14 different studies, putting together all of these Nexus, CCR, all these other studies to further determine if imaging was needed. And clearly everyone says no further imaging was needed to clear a collar if the patient remains alert and unaltered. So not intoxicated, not under the influence of any other drug use. If they're asymptomatic with no neurologic deficit, meaning they are moving all 4 extremities, they're not complaining of paresthesias. They have complete free range of cervical motion exam. So again, that's that segue back to CCR recommendation. So are they able to kind of look from side to side, up and down with no pain? And there is no clinical signs of distracting injury. So there's no long bone fractures. They don't have some big, lack or seatbelt sign. These would be ones that you can very safely clinically clear. And we would say the negative predictive value of this was 99.8%, so almost 100% with a 98% sensitivity. So pretty good. discussed. But these patients coming in talking on their cell phones can probably most commonly be cleared. So again, this is just another way of looking at it. No posterior midline cervical tenderness, no focal neurologic deficits. They're not intoxicated. Normal level of alertness. We're not worried about, another head injury, concussion, and no distracting injuries. So this is recommended in adult blunt traumas who are asymptomatic and have negative CT imaging as well. So this further extrapolates. So in our patients, often because they're coming in and they do have other injuries, they may be post-concussed, they're maybe drunk and or under the influence of some drugs, we will get the CT scan. It's kind of one of those things, like you don't do a head CT and then skip to the chest. You might as well just get the cervical spine anyways. But if you see us and we have that CT and it comes back that the cervical spine is negative for any fractures, we will kind of tell you guys to remove that collar. What's also important here is that when we do get that CT scan and that negative CT scan, this is now saying we're sufficient to remove the collar in those patients who are obtunded and unevaluable. So they're saying CTs have gotten so good that we're confident enough that you can actually remove the collar. But just to keep in mind here, 2 to 6% still have cervical spine injury and blunt traumas. It's recommended practice for EMS to transport all patients in C-spine motion restrictions, so that SMR, until further assessment is made by your appropriate providers. What this leads to is 5 million patients being placed in cervical collars annually. So we should probably all own stock in these extrication collars. And keep in mind, again, these can be worn for up to 2 hours. So you will see us, and it's actually within our policy here, that we will leave these in place, especially if we think that, more likely than not, after the imaging is done, we're going to be able to clear these. So do not waste and put on a nice aspen collar. We'll quickly get these off. If, however, your patient is going to have delayed imaging for whatever reason, they need to get a procedure done first, they are getting an extremity reduced, they need to go to the OR, perhaps these patients are being transferred across the river, or there's another actual injury that is identified, that is when we will have the team switch them to an aspen collar. So again, we're always kind of keeping this in mind and knowing that we want to get these collars off as soon as possible. Excuse me, back to our older patients. So our typical ground level falls. So remember that Nexus does not include age-related contingencies, and the Canadian rules were all for greater than or equal to 65 as a risk factor. So it's very hard to kind of clinically clear elderly patients. Oftentimes their pain is not perceived in the same way, and or they'll have, because of all those underlying comorbidities that we had talked about prior, they could have a fracture sneaking in there. So 20% of these patients older than 55, their spine fractures truly were asymptomatic. So this is why, too, we're also a little more liberal when I say, oh, we're getting a head CT and we also need to check for rib fractures, but we're just going to go ahead and throw in that cervical spine because these will always tend to sneak in. Excuse me. Always tend to sneak in, and never surprises us when they have an extra fracture somewhere along the spine. Let's see. So this is Peace Health. This is the trauma department's cervical spine clearance algorithm. I know it's kind of hard to probably see on this, but you can get this from Crossroads. It is in our spine CPG. It's essentially kind of exactly what we've been talking through and walking down. So when a patient comes in, do they have any of the followings? So again, those 5 criteria that we keep talking about. If they do not, then the spine can be cleared. if one of those is positive, we kind of keep walking down. So we will obtain that CT cervical spine. If it's abnormal, we'll place the extended wear, call neurosurgery, and you'll see some special orders for that. If it's normal, here's some kind of special circumstances that may occur. And this is what our trauma department has deemed as what our next best step is for us. So if they do have a normal CT, but they have continued cervical spine tenderness, we will discharge in that Aspen collar and have them follow up with neurosurgery. So neurosurgery, so we'll say wear the collar for comfort, follow up with neurosurgery. Oftentimes the pain goes away. It's a musculoskeletal pain, kind of whiplash, muscle spasms, and it goes away over the next couple of weeks and they're fine. Oftentimes they'll get FlexX films in the clinic. Neurosurgery then will follow them up. If the patient's intoxicated, this always used to kind of be a big buzz, like you'd have to wait, but we can clear these. So again, the CT is so good that we can clear, but I will say if the patient has a normal neurologic exam, so still we have to watch, make sure you're seeing them move all four extremities, there's no focal deficits that you're experiencing, and are they alert enough that they'll kind of talk with you and still follow along with an exam enough to know that you feel pretty confident in taking that collar off. If they have a pretty nasty distracting injury, we often will keep that collar on. We'll switch to the Aspen, let them go, get their operation, get their femur fixed or whatever. If they're clear with it and clear enough that we can, obviously we'd like to get that collar off, so then anesthesia is a lot easier. But if not, we reassess later. This is how oftentimes you'll see us come back by and do that tertiary exam, either later in the day or the next morning. Again, just giving time for everything to kind of settle out, pain to be controlled, to really assess these patients to make sure we're not missing something. Clearly, if you have a normal CT, but you still have a focal neurologic deficit, that's something's not adding up. So this is where we would get an MRI and consult neurosurgery. And then in the obtunded and intubated patient, so you can clear, we do take off the collars if we are seeing all four extremities moving. Again, there's always the discretion of neurosurgeon, trauma surgeon, or ED physician that can clear this, based on their judgment as well. So documentation, where do I look? So, where in the chart do I find that someone, physician, trauma surgeon, neurosurgeon, has appropriately evaluated and cleared the patient is often a question or concern, or we'll get called and asked, hey, is this cleared? And we're like, yeah, it was written here, look here. So it can be written in notes. So the primary RN, especially in the ED, they're perfect. They will write little snapshots as we come into the trauma bay, and they'll say, trauma surgeon Stephanie C at bedside, cervical spine cleared. So that's one way to look. The trauma team, we try in our actual HMP, it's often embedded in the vast majority of our notes, like a cervical spine blurb or physical exam section. So that will tell you, that everything has been cleared. And I believe the ED physician probably also has a section in their notes as well where this may become apparent. Other places to look is the physician orders. So again, when we do our trauma admission orders, we like to click the little checky boxes that will say cervical spine cleared or cervical spine not cleared, and then we'll put in some additional orders on, maintain cervical collar at all times. So you can look for that in the physician order section. You can also look in progress notes. So, perhaps this patient was just so sick, they went directly to the OR for something else. And so it was never really clearly documented in the ED. So, we often, or say we did it in a tertiary survey. So you can always look in the progress notes. We try and document clearly in the tertiary if there's any spinal precautions whatsoever. And then obviously change the appropriate order. Certainly these things fall through, so we always ask, just send us a secure chat, call us, text us. If you know there is an injury, neurosurgery is also really good people to reach to, because oftentimes The trauma surgeons, trauma PAs, we don't even know, because it's so individualized. We can say, yeah, no, cervical spine is definitely not cleared, but reach out to neurosurgery and they will give you clearer expectations on say, their collar wearing. The patient that arrives from an outside hospital may be already clinically cleared by that physician from outside, so there's no need to replace the collar once they during transport or once they get here, unless something has clinically changed and you're suspicious. Then obviously we'll throw the collar back on, but otherwise no need to throw it back on. If not clinically cleared, no imaging obtained, change the extrication collar to that extended wear. So again, trying to minimize how long they're in that collar. Some other unusual circumstances that may pop up. So if a patient's intubated, they have a normal CT collar, and then all of a sudden they wake up, they extubate, and all of a sudden they're like, oh, my left arm feels, weird and has paresthesias, and I'm not actually moving it appropriately. Put the collar back on, call your trauma team, and we'll come and assess and most likely get an MRI. But no harm done there. This can happen, and if it does, we just move on from there. Intoxicated patient, again, if talkative, interactive, moving all four extremities, take the collar off. And if they're discharging from home, again, we put them in the collar, followed with neurosurgery with some Flex-X films. Let's see if this works. It's probably not going to. Again, this is the wonderful, we'll link this as well, but this is our Aspen collars, the Vista. This is the most common. This is what is used here. This is a very nice video to show appropriate sizing, how to adjust it appropriately under the chin, making sure it's in the correct spot. This will also show you if you have a morbidly obese patient, one of those that has no neck, when we call hanger and ask for special collars to come in and be adjusted. Also with our really frail, elderly, teeny tiny 80-year-old patients, they sometimes often need a pediatric collar. So this will kind of show you, again, things to look out for. So let's go back to CB, our patient. So when he came into the hospital, this was actually his exam. So he was showing upper thoracic tenderness to palpation. He had obvious laxity and crepitus on palpation around T5. And at that point was starting to notice some decreased sensation, which he was reporting as kind of dull sensation. He had clearly no active range of motion to bilateral lower extremities. So he was kept in strict spinal precautions with a cervical collar, because again, bad distracting injury, we know 2 injuries can happen along the spinal column. He was appropriately log rolled and sent for imaging. So let's talk about imaging real quick. And I noticed our time, I'm maybe not even halfway through this talk, so I'm going to start speeding up. Imaging, x-rays, not recommended. That's the kind of old imaging. We do not do x-rays, we do not manage. So to appropriately assess these injuries, you need at the very least a CAT scan. That is our initial imaging of choice. So they're going to be the most sensitive, and for C-spine and T and L spine. These are all done with this multi-detector. That's what our CTs are, so you don't have to worry about that. MRI. So MRI then is only used when we're actually looking for ligamentous injuries, spinal cord injuries, nerve roots, discs. So this is an adjunct and complementary to the CT. So we very rarely would go straight to an MRI, I guess maybe perhaps like in a pregnant patient, but CT's first. It's quick, it's easy, it's accessible. It finds the vast majority of injuries, and then for further imaging and unexplained injuries, we get to MRI. Another thing that you'll see us do is always in the back of our mind, we're thinking of blunt cerebrovascular injuries, or BCVI, incidents associated with spinal cord fractures and injuries, incidence of up to 7.6%. So kind of 3 to 7%. Highest risk is with C-spine injury and subluxation. So that's when you'll see us hopefully try and sneak in a CTA neck, looking for the carotids and vertebral arteries, because those sneak up right through the spine, looking for injury on initial imaging. Sometimes we forget or we weren't really suspicious, and then based on the fracture pattern, we're like, ooh, clearly need that CTA. So that's why you'll see us asking for patients to go back. Sometimes it's at that 24-hour mark because perhaps they have impaired renal function, and so we need to wait a day for that contrast to wash out and then give them another contrast load. So again, looking for those carotid vertebral artery injuries that can have a pretty high mortality rate. So again, if left untreated. And the treatment's easy. It's usually just aspirin. So that's why we really want to identify those early on. When do we look for all these injuries? So when we're here in the trauma bay, we got the patient on the table. This is all during primary and secondary surveys. So we're following ATLS. Primary survey, we're maintaining cervical thoracolumbar restriction, and it's that D. So you always hear follow your ABCs. Well, there's D and E, and D is that disability. So we're quick assessment. Are they moving their legs? Is there any lateralizing signs? It's easy. If they're awake and alert, you just say, hey, can you move your arms? Wiggle your fingers, wiggle your toes. Easy, done. Your disability is quickly assessed. And those are some quick, easy ways to see. Signs that you may see is like all of a sudden they're like, oh, I can't feel something, or oh, I can't wiggle my toes. That would start to kind of clue you in. Other things that might clue you in is absence of equal movement, complete partial loss of muscle tone. So they just kind of appear flaccid. Their legs just roll out to the sides. They have loss of bladder or bowel function. Priapism in male patients is often indicative of spinal cord injury. Perhaps they're tachypnic or diaphragmatic breathing. Clearly in a trauma situation, this can be related to multiple other things, but something we start thinking about. It's kind of all these things that we're looking at when we're doing primary, secondary surveys that we're all kind of keeping in the back of our mind and just adding up to what could potentially be the problem. And then if you have a patient that comes in and they're just crazy hypotensive, they're bradycardic, but they have no other visible signs of trauma, you know they're not bleeding, their FAST is negative. In the back of our minds, we're always thinking, hey, is there some neurogenic shock here going on? This is a wonderful video showing you appropriate log rolling. Check it out later. This is when patients come in. This is why we need so many people in the trauma bay. You're crossing your arms. Someone at the head of the bed is maintaining. She does a really excellent job. And what I wanted to point out is oftentimes people will grab the head and or the collar thinking that I'm maintaining spinal motion restriction, but you're not. You can still allow that head to move on its axis. So really, the lady here is demonstrating really good control where she is grasping kind of at the traps or at the shoulders and cradling the head and neck in her arms as the people are rolling. And I think that's a really good example of proper C mobilization or spinal mobilization restriction. So check that out if you get a chance later. This is just other things to keep in mind. So these spinal fractures and spinal cord injuries always have a way of sneaking in. So, we clearly see big brain injuries. We see maxillofacial trauma, so nasty facial fractures, pelvic trauma, rib fractures. But we should always be thinking these are often associated with underlying other injuries kind of down that spinal column. So brain injury, facial fractures, all related, will have underlying or associated C-spine injuries as well. Pelvic fractures, just because the sheer force that it causes to have a pelvic fracture often means you're going to get related spinal injuries as well. Ribs, sternal, scapular, clavicular fractures, very associated. You can just imagine those all in the area, particularly if they're posterior, you're going to see some associated cervical and thoracic spinal cord injuries as well. This one's a pretty telltale sign. Someone falls from height, lands on their ankle or their feet, so they get calcaneal fractures. Again, remembering that force is moving up through their back and will have associated lumbar injuries. Seatbelt sign. This one may not be as obvious to people, but in a seatbelt sign, you know, clearly we're all worried about the belly and associated bowel injury, but actually that flexion, that force will cause thoracolumbar injuries as well. And so that's always something that we need to look at and think of. So this takes us back then to CB. This was our kid, the motorcycle to the tree. This is a nice quick snapshot of one of his biggest injuries. So remember, he was not moving his lower extremities. So you can see the big obvious injury here is at T5, T6. He has retropulsion. It's affecting his spinal cord. But you can see he's got a whole host of associated injuries. So it just goes to show that these kind of all come together. Again, when I share this, oh, here, this actually may be linked. Oh, this one worked. This is scrolling through his spine, and it is obvious, nice, clear as day, that his thoracic column just got crunched. So here you can see these are some of his burst fractures. He's got facet and spinous and transverse process fractures, rib fractures, everything, and just really bad impingement back here on his spinal cord. So this is a really cool example or CT to go through if you want to see some pretty devastating injury here. And just something nice to look at. So he also, oh, hello. Well, that crashed the computer. So he let me go back here. So he had rib fractures. He had actually cervical injury. Let me get back to him. Pneumothorax, pneumomediastinum, pulmonary contusions, all the such. I'm not going to belabor this. You will see this referenced, and it's used a lot for neurosurgery as well as rehab. You'll see these ASIA scores. This is used to identify rapidly the level of injury. I'll show you his score here shortly. It's a best practice tool to document level and severity of spinal cord. It's a really good way of like communicating across, like from the neurosurgeon and or some places it's orthopedic surgeons that are your spine surgeons, and then continuing into rehab on your physical therapies. Not sharing apparently. Did that work? I hope so. I'm sure you guys will come in and tell me if not. So this will, excuse me, give you a good tool as to what's going on. I won't belabor this, but these are all really good points to come back and look at to make sure. Common types of spine fractures that we see, compression being the most common, burst, chance, Jefferson, Hangman's. I'm sure all of you guys have heard those. Burst fractures. So mechanism is axial loading, and you'll see that actual burst or kind of splaying out of the fractures. That's what our gentleman CB had. I know our time is getting close, and so I don't want to belabor. If you can stay on, I can continue and power through this. If you do need to jump off, I do want to let you know CB, who had incomplete paraplegia, our team, and I want to include all the nursing staff, PT, OT, all the therapies. He ended up going to our IPR. 1 year out, he is jogging. So he went from no motor, wasn't moving, left in a wheelchair, to now being able to kind of lightly jog, and he is getting around. So out of anything, he is a major, major success story for us, and just goes to show that the team really did a lot of hard work. So he had a lot of sequelae of spinal cord injury that I was hoping to get to, which clearly I'm not going to. But just this was kind of the highlight, is that this was a huge success story for us. So let me go through. So this is, if you guys would like, go back and look. These are really breaking down all the different fractures. It will talk about ligamentous injuries. It will talk about kind of the underlying, which ones are stable versus unstable, which ones are more likely for neurosurgery to operate on versus us to keep in immobilization. So I go through all of these types of fractures and really try and highlight that. I touch on common spinal cord injury. So now moving outside of that bony fracture to the actual cord injury and where motor and sensory run. And that's really then shows us and is indicative of what kind of clinical picture we're looking at. So big injury classifications that we talk about, tetraplegia versus paraplegia. So tetra, of course, being a high cervical thoracic injury. So you will get complete paralysis of both upper and lowers versus paraplegia, which will be your lower extremity and preservation of the uppers. We also talk about incomplete versus complete spinal cord injury. So incomplete, meaning you have some residual function. So CB, our patient today, he was an incomplete. He still had sensory. He had intact rectal tone, which leads to a better prognosis. And potential for regaining function long-term versus the complete who will have nothing. They also then tend to have higher morbidity, mortality, and associated complications later on. These are some very common incomplete spinal cord. Our most common and what we see here a lot is that central cord syndrome. So kind of go back through and familiarize yourselves with some of these syndromes that we will see. Non-operative management. This is by far the most kind of common, and this is what we see. Everyone ends up being in cervical collars or TLSO braces. So unless, again, everything is treated back on an individual basis, and that's why these injuries and injury patterns can be so frustrating, especially when these patients get to the floor and dealing with bracing and moving and precautions, because they literally are so individualized. The fracture patterns are so specific to the patient's comorbidities, what's their bone structure. Sometimes we often watch them and we'll have them bear weight, get up, have some what we call axial loads, see how the fracture pattern moves. Is it stable, or did the compression, cause us so much more compression that we actually have to have more stringent spinal precautions? So again, I will urge you, especially if nurses, PT, OT are on here and you don't know, just ask. Reach out. Again, oftentimes you're reaching out to trauma PAs. We may not have that answer, so we'll have you or kind of link you to the neurosurgery PA or neurosurgery staff. Again, that's kind of their bread and butter, their cup of tea, and they really will have a better fundamental understanding of the fracture pattern and the patient and be able to kind of assess that and know what's best for the patient. Alan and or Danielle, please put in the chat whether or not you want me to stop. This literally, I'm just going through, this was back to CB. So he had that acute T5, T6 burst fracture. He went emergently to the OR for fixation, decompression. He was listed as an Asia B, T5/6 incomplete paraplegic. So this was his MRI after the stabilization. So you can see there's some decompression of that spinal cord, and you're actually seeing that nice spinal cord return. It still looks like a bomb went off in there, but obviously much, much better and improvement from what he was. He maintained a C-collar for his C6 facet fracture, but didn't actually require further bracing for his T-spine. So he just got early PT, OT mobility, and because he was already fixed, we did not have to do a TLSO. So again, one of those very individualized kind of bracing that's going to be individual to the patient. This is where I really wanted to focus, because this is where nursing, you guys do such a phenomenal job, PT, OT, nursing staff, on the continued care of our spinal cord injured patients. Really talking about neurogenic versus spinalgenic shock, spinal cord injury induced bradycardia. When we talk about steroid, no steroids, all the such you can see. So I'll kind of quick go through and just hit some high points. Neurogenic shock associated with lesions above T6 occurs in 20% of the patients, and this is a loss of sympathetic tone. So there's now like an imbalance of sympathetic and parasympathetic tone. Big things here is maintaining MAPS. Old goals used to stay above 80, 85, 90, which was crazy, right? We were going to have to give pressors and a ton of fluids, and these people get volume overloaded. And you can imagine all the comorbidities, especially with our older population, that may not be sustainable. So now people have gone more to keeping a goal systolic blood pressure above 90, keeping normotensive, if not a little bit higher if you can, and just avoiding hypotension. So again, early use of vasopressors, volume, resuscitation. This is all to maintain spinal cord perfusion. So we're trying to reduce ischemia to that spinal cord and preserve as much function as we can for long-term, better, more function. We talk about spinal shock. This is actually total or near areflexia below the level of injury. So this actually is a temporary thing. It can happen for days to weeks after the spinal cord injury, but this will resolve and resolves faster with incomplete injuries. Spinal cord induced bradycardia. So we do see this and see this a lot with our cervical spine injuries. So it's the most common dysrhythmia in the acute phase, often precipitated with the suctioning, the infamous turn, bathing, hypoxia will cause it. It's often transient. However, if it is persistent, the use of a beta-2 agonist, chronotropic agents, PDE inhibitors, although I don't think I've ever seen theophylline actually used here, but that will help control it. Steroids versus no steroids. I will tell you, no steroids. It used to be kind of all the fad in the 80s and 90s, and then it just led to a bunch, as you can imagine, a whole host of other problems. So again, very, very, very rare that you'll see the neurosurgeons actually order steroid. And it's usually for 7 days. DVT prophylaxis. This is extremely important. I think we are pretty aggressive here about it. You will see us hold it if there's associated epidural hematomas, or if they just came back from a really big kind of bloody spine surgery. They have drains that are still bloody. You may see just like a heparin BID, but we do try and transition to that Lovenox, which would be key as soon as possible. So again, trauma and neurosurgery kind of working together to try and get to DVT prophylaxis at ASAP. Incidence with these 40 to 70%. So they are real. They do get DVTs, highest obviously during that acute phase, so within the first 3 days to 2 weeks. But they can get chronic VT for up to a year post-injury. So it's something even in the post rehab phase is always being talked about. Respiratory insufficiency, as you know, especially with cervical spine, high cervical spine, these patients all get respiratory insufficiency. So reduced tidal volumes and vital capacity, impaired cough, accelerated fatigue. So we'll use CPAP or BiPAP, intermittent positive pressure, high flow, ways to kind of keep their oxygenation up. Patient positioning is really important. Cough assist and quad coughs. You'll see that we'll CPT beds, metanebs, all uses. But again, if you have to, early tracheostomy is always key in getting these guys established airways because it most likely will be a long-term thing for them. Autonomic dysreflexia is a super cool thing. It does happen. It's even in PM&R's notes is something to look out for. So just to remind you guys, it's can happen with the spinal cord injury at T6 or above, and it's triggered by some random stimulus. So restrictive clothing, pressure ulcer, they have a full bladder, they need to have a bowel movement, and it will just cause ridiculous high blood pressure, followed by vasodilation. So they'll get flushing in their faces, they'll get diaphoresis, they'll get a horrible headache, bradycardia, increased sweating. And this is something that needs to be treated very quickly. So because it can cause life-threatening stroke, seizure, MI, pulmonary edema. So this is why it is really important to kind of keep in the back of your mind and identify with these high spinal cord injuries. So treatment, sitting them upright, getting them back in that, removing any inciting, and so getting tight fitting clothes. If they have an abdominal binder, getting that off, making sure their Foley is flushed. Do they need to have, a disimpaction? Do they have any other distracting injury from below? Something as simple as like, I've read an ingrown toenail can cause this. If it continues to persist, a short-acting antihypertensive can be given to help get that blood pressure down. If you actually look in the PM&R notes, their recommendations for persistent autonomic dysreflection, I took this quote for quote from them: administer 1-inch topical nitro ointment. This has the advantage it can be wiped off if your blood pressure gets too low. Another option would be PO hydralazine. So again, there's recommendations within the chart for this. And ultimately, prevention is key for these. Other issues that always pop up, analgesia is always an issue. So these guys are often on multimodal pain controls, Tylenol, gabapentin. Spasticity becomes a problem. So this is often managed with physical therapy, but sometimes needs medication. So baclofen is a very common drug that we see in these patients. Contracture prevention, so multipotus boots, decubitus ulcers. So are we pressure offloading, moving them every 2 hours in bed, daily skin inspections, because these have very high morbidity and rehospitalization rates. Neurogenic bowel and bladder becomes a very big issue. That's why all of our patients most often will have Foleys. We tend to wait for bladder training when they go to rehab. However, sometimes these patients get stuck here for very prolonged extended stays. So you may see our PM&R colleagues will help assist us with bladder training while in-house. But another big important thing is neurogenic bowel. So that's why these guys need to have bowel movements daily, and why we get so overly focused on these. Providing these daily enemies suppositories with scheduled pericolase is extremely important. Again, you don't want to get that autonomic dysreflexia and have a really bad problem. Mobilization and rehab is extremely, extremely important. That's why we talk about early mobilization. And this is done in the ICU very easily, or at the bedside if they get to go up to the towers. So driven by bedside nursing. So your passive range of motion, repositioning in bed, lateral transfers, sitting up in cardiac chairs. This all starts the rehab process and gets them to better function right from the beginning. So it's extremely important. Beginning with PT, OT, getting those consults in and working with them ASAP. And as well as we found early PM&R engagement consultation also helps, because again, they can get us on the road to recovery much faster. And the goal ultimately is reducing those secondary complications and improving functional outcomes. And ideally, what we would all love in a perfect world is to get every single one of these patients to inpatient rehab whenever possible. So we all try and go for that. Real quick, just to regroup back to CB, if you're here. So in hospital, he did have neurogenic bladder. He had a Foley catheter that was maintained until he went to IPR. He also had pretty severe neurogenic bowel. So he had aggressive bowel regimen, daily suppositories. He actually required daily, I think, BID lactulose just to stay regular and disimpacted. He had extreme difficulty with pain and muscle spasms, was on baclofen, gabapentin, scheduled Motrin, Oxy. I will tell you, a year later, he has finally just gotten off, I think, the last of the baclofen. So he is now prescription or drug-free, which is also fantastic. He required multipotus boots while he was here, again, to prevent any contractures, which clearly you can see helped, because now he is able to stand and walk and is not having to deal with a lot of contracture issues long-term. So again, this is his rehab course. So after, I think it was 2 weeks here with us, he had 1 month inpatient rehab. So he went from being strict paraplegic to now being independent with wheelchair transfer. So he was gaining a lot of mobility back even at that discharge. By the time he went home, he was walking short distances with the family with a support walker. Fast forward another month, he was walking 500 feet independently and walking upstairs now, which is just fantastic. He was still working on his bowel and bladder issues, but they were significantly improving, and he was weaning off pain medications, still keeping some baclofen and gabapentin. 2 months post-discharge, walking with 1 to 0 crutches. By 1 year now, I just saw a note from June with outpatient PT, and he was noted to be jogging and off all his medications. So again, huge, huge, huge success. This was a really funny video. I urge you all, if you get the chance, to go back and look. As I was going through my videos and looking at this hospital actually took the perspective of putting the camera from the trauma patient and walking him through pre-hospital, trauma bay, being in hospital to discharge. And it's actually quite engaging and funny, and just a different perspective that we clearly don't get being on the other side of the table. So if you all get a moment, go back and watch this video. It's really quite wonderful. And thank you for, while suffering an extra 15 minutes with me. I can stay on and answer any questions. Clearly, please reach out via email. Stop me in the hall. I'd love to chat. This topic is just so broad and so extensive. We could sit here and have a whole mini series for days on all these topics. So yeah, please reach out, and I'll make sure that when Alan sends this out, the links to the videos are there, because they're not very easy to find online. I will tell you that. So we will get them all to you guys. Okay. Oh, go ahead.
Sorry, Dr. C. I was just going to thank Dr. C for tackling. This is a very large topic, and it's been one that's been requested multiple times. And so I applaud her for taking on this challenge, and I also applaud her for doing it with such grace under, very difficult circumstances when technology decides it's no longer going to be your friend. I will put those links into the chat box now, and then once the video's ready, processed, I'll have it in there as well so people can pick up the spots that they missed.
Cool. Tom, I see you said obtunded patient C-spine precautions can be entirely cleared by CT. Yes. So yes, they can, as long as we're seeing all four extremities move. So in the obtunded patient, if we see all four extremities move, CT cervical spine is negative, yes, that cervical collar can be removed. Can you speak to ligamentous injury and when this is an issue, or if it would even require? Yes, it often does require a C-collar, but again, you don't know ligamentous injury unless you're getting an MRI. So if you have a high suspicion, if they have some injury, if they still have pain, that's when we keep the cervical collar. We'll order the MRI, or they're still having issues and it's just not adding up. So we'll order an MRI, and maybe their collar's already been cleared, but we'll order that MRI. Based on what that MRI shows and those ligamentous injuries will depend on whether or not they need spinal restriction. And again, that'll be very individualized. Is there anterior ligamentous injury? Is there posterior? Is there all three columns? Because a lot of them, ligamentous injuries, if it's just one, they can still be stable. But now if you're dealing with multiple ligamentous injuries, that may be an unstable injury and they may require a collar and or surgery. So again, it's so individualized to the injury and the patient that that's kind of a as needed basis. And it would be determined based on neurosurgery's recommendations. So you'd have to ask, get a little more in-depth questions on that. That's not an easy answer for y'all. And then, yes, you guys can definitely have every single one of the slides. All right, thanks again, you guys, for fighting through this with me. Love to chat anytime. All right, have a good rest of y'all day.
Thank you, Dr. C.
Thanks.